I'm Dr. Tracy Pesut. I'm a foot and ankle specialist at Tennessee Orthopaedic Alliance. This is my new partner, Jo Baird. She is a sports medicine specialist. We wanted to thank you and welcome you to our podcast here at Orthocast.
Jo, what sparked your interest in orthopedics?
Well, being an athlete my entire life, it was sports. And ironically enough, foot and ankle, I sprained my ankle in middle school, had a high ankle sprain, saw a orthopedic surgeon in my local area back in Jersey. And it was just, I was like, this is what you do? Like, this is cool. And so after getting through wanting to be a marine biologist, train dolphins, and I finally decided on med school, it was the hands down pick once you were, in medical training.
Yeah.
How about you, Tracy?
So I actually started off wanting to go to medical school because I had a good friend in 6th grade who died of cancer, and I was going to be a pediatric oncologist.
Oof.
And I went to med school in Memphis and spent a day at St. Jude's, and
Oh my
I was a
gosh.
basket case and was like, I can't do this.
No.
It takes very, very special people to do that.
Yes, it
So
does.
then I kind of reevaluated. I, as well as an athlete, played soccer all through high school. And I was like, I want to do something where I actually help people and I see happy things on a daily basis. And so when I did my orthopedic rotation, I was like, well, this makes sense. I was an athlete. I understand where they're coming from. Luckily, I never had any major injuries growing up,
Knock
so
on
that
wood.
was a good thing, knock on wood. But I was like, I can take my experience, I understand the athletic mind, and help people get back to athletic activities, get back to life, and really help people get better, which was very
No,
rewarding
and that's
for
so
me.
important, having that understanding of being on that same side as the patient. I think it just helps when you're counseling them and coaching them through an injury because, some of the stuff you do, it's 6, 9 months, a year
Oh, yeah.
before we're getting them back to their activities. And when they first hear that, it's like the end of the world crashing down. But yeah, I also, in med school, I thought about pediatrics for a brief blip of a
Okay.
minute until the first runny noses and earaches and colds. And I knew primary care and internal medicine was out. Like, you just circle, and I felt like you were just like rounding all day. Surgery, especially orthopedics, was that easy, like immediate gratification is kind of, but it's true.
Yeah.
You literally leave the OR and know that you've just restored that patient's life back to them and could see that difference clinically when they see you back in clinic.
Definitely agree. How'd you choose sports medicine?
Sports. So when I was in the Navy, funny enough, in residency, I thought about hand because we did a lot of sports. That was our residency, was basically a sports practice. So we got a lot of training in it, but for fellowships, it was hard to come by. And so I said, well, I like hand. It gives variety. Most patients, they're shorter surgeries. They go home. It's not a lot of inpatient. And then I got into general practice because I didn't get selected for a hand fellowship with the military, which is a whole other process beyond the civilian sector. But I really didn't like hand. So it was a blessing in disguise.
Yes.
And eventually realized my favorite surgeries were the scopes, the ACLs, the rotator cuff, shoulder instability, and all of the sports stuff. So finally applied to fellowship, and it lined up with my time out of the Navy, and I got my dream fellowship with Andrews Institute, and rest is history.
Yeah. Which is funny because that's where I did my foot and ankle fellowship with
Really?
Dr. Gould.
Yeah.
Yes. So we were in
How-
Birmingham at the time, but were you
I was down in Gulf
down
Breeze.
in Gulf Breeze once?
Yeah, he had
Dr. Andrews had
started
moved
the
down
second
there.
one. Yep.
Perfect. Yeah.
But-
It was a great experience.
Yeah, and Birmingham's an amazing center,
Yeah.
and they've got great fellowship training. How'd you pick foot and ankle?
So our foot and ankle specialist, Dr. Tarquinio, was great. And he just kind of inspired me to, which is weird because most people are like, feet are gross. But I'm also like a lot of diversity. And
Yeah.
so kind of like sports, like we do a lot of different things. So I do everything from sports medicine with ankle sprains, Achilles, to trauma, to reconstructions. I like the big, total ankles.
That's awesome.
Yeah. Flat foot reconstructions, all that kind of stuff. So I never do the same thing really twice in a day. So it kind of provides variety. It also gives me kind of a variety of patient population.
Yeah.
So you're
Young
kind
to
of dealing
old, the
with
full spectrum.
Exactly. So it's just very satisfying and kind of keeps me on my toes, keeps me learning.
Yeah.
So
Foot and ankle, it's come a long way with the total ankle and some of the procedures. We just didn't have it. I think, so much of your interest from residency is based on who you work with.
correct.
Right.
We did not have a lot of good foot and ankle.
Mhm.
There was a great surgeon that I loved her, and she was very passionate. I mean, she loved the foot. And I'm like, how can you love the foot so much? And the joke was always the foot's just the dumb hand
Yes.
because there's a lot of parallels, but she was great at it. But our rotations switched, and so I never got a dedicated foot and ankle as a junior resident. And so it was, the lack of training. I was like, I just don't understand foot.
Yeah.
It's not me.
Yes. Well, and there aren't too many of us. I was like, it's kinda surprising to me, that there aren't more because I guess it's kind of a relatively new,
Yeah. Specialty.
subspecialty, and so it's been kind of fun to learn and see even I've been doing it for 20 years and the things
Yeah.
that have changed from back in the '90s when they started doing the first total ankles again,
Yeah.
and how much that we've
Progress.
learned from total hips and total knees and the things
Well,
that they've
even
kind of
Achilles, I mean, our
incorporated.
rehab is completely
Oh, yeah.
different from the studies were just coming out when I was in residency and discussing, and then the functional rehab, like what we've learned on just basic science of tendon healing and
Yes.
recovery is insane. But
And it's nice to get people moving earlier.
well, yeah, I mean, it's the AO basics of the
Yes.
bread and butter of orthopedics. Like why we fix fractures is early mobility
Right.
and early restoration, which decreases all the complications and the problems of stiffness and things.
Yes.
So that's why we went into it.
Exactly, and you're constantly relearning. In
Yeah.
fact, one of the funny things that I think recently is with ankle fractures, like we would fix them, and then we found out that people actually had a lot of medial deltoid insufficiency,
Yeah.
and so probably in the last 5 years, I spent a lot more time focusing on fixing medial deltoid and bimal fractures and things like that, or
Wow.
syndesmosis injuries that we never did before, and even, some of the people that have trained not as recently probably still don't do that and still do some casting, which is interesting to me because 'cause I'm like you said, we're trying to get people moving to get the tendons,
Yes.
get the ligaments to heal better, and so you put someone in a cast for 6 to 12 weeks, and they're gonna be stiff, and they may never get that
Stiff, you
motion
get
back.
atrophy, just the muscle wasting. I mean, it's
Mhm.
3 weeks to 1 week of not using something. I mean, it's quick to lose, hard to get back.
Mhm. Same
But
thing with ACLs because I remember they used to immobilize those,
oh,
and
yeah.
now you get them rehabbed before they even have
Yeah, I mean,
surgery and
motion, and that's where it's tough. I mean, you get some of those bad meniscus tears, and the counterbalance is, you don't wanna move them too fast, but then if you don't, they're gonna get stiff and lose motion, get the scarring in the notch, and then you're coming back to, scope and debride them again. Rotator cuffs, frozen shoulder, I mean, it's just so much of what we do is kinda weighing
Yep.
minimizing, but trying to maximize other areas. But how was it? I mean, as a female, I had a more unique experience. I had probably at least 1 resident, if not 2 a year that were females.
Oh,
And
wow.
yeah, I mean, we
That
were
is
one of
impressive.
5 in the country that had more than 20%.
Yes.
But I'm sure when you trained,
Oh,
like,
yeah.
you were it.
Oh, yeah. So I was the first female in my program. So
Wow.
I did my residency in Jackson, Mississippi, and
Deep
my
as
chairman yeah, deep South, my chairman, they were excited to have a female. I've always been very kind of a strong personality.
Yeah.
And so coming on, I was definitely nervous because I did not see myself as a trailblazer. I was just like, I like orthopedics. I want to do this.
Yeah.
This is what, I want to do with my life. So, but Dr. Hughes was great. He was definitely a true gentleman. He was completely supportive. He basically told the guys, if I hear anything, she's coming straight to me and
That's
that'll
awesome.
be it. So I had 19 guys with me and I mean they teased me, but if anyone messed with me, they were the first to mess with
Yeah, they were
them.
your
So,
brothers.
yeah. So
Yeah.
I had I think a special and a unique experience. I do feel very lucky to have the support of my chairman. I
Yeah.
know a lot of other women that had not as nice of an experience as I had, so I'm very thankful for that. I did have friends that were females in other surgical fields, so I think that helped. I
Yeah.
had a friend who was an ENT, I had a friend that was general surgery, and then it's amazing to me, like I said, it's been 20 years that even in foot and ankle, like just seeing the transition of more and more
Yeah.
females into the field has been kind of exciting.
That's okay. Yeah.
And being able to kind of mentor and support some of those women has been kind of nice too. So, but now from a military standpoint, that your training, did you have anything different or unique that
Yeah, I mean, it was it adds a whole other element. I mean, you were worrying about deployments and all the military requirements, but we were good. I mean, funny enough, we had female residents. There weren't many before me, but after me, there were several, but we didn't have any female staff. And our chairman, similar to yours, was very like, this matters. We need some female mentorship, and had recruited three, 2 or 3 female staff. So after I had gone out on the ship and come back to residency, there were now 3 staff, which hadn't been there before. So it was helpful. But it's funny because even with that, I mean, different women were just,
Yeah.
and I found my closest mentors. I mean, one or 2 females, but I still had as close of mentors in the male, the trauma guys that, again, bantered back and forth and just good old boys. I mean, being sports, I think it is a little different for us. Like, we're just kind of, you know, can get around with the guys
Yes.
and stuff, and it's fun. And part of that's still within the field of orthopedics, but um, I think it's good for patients that now we have more of a variety, and it's, which each surgeon brings a slightly different perspective to how they approach patients. And so I think that's nice for our patients that there's a little more out there for them. But, first and foremost, including the patient in the discussions and team kind of counseling, teamwork to get them through the injuries and the surgeries and the recovery.
Agreed. I think half of what we do is relationship building because patients that are facing an injury or facing surgery want to have trust in you and want to
Yes.
feel like you have their best interest. And so, like you said, some of it's personality based. Some people do prefer female. I do have some women that are excited to see female surgeons. But I think overall, people just want a surgeon that's good, that listens, and that kind of takes good care of them.
Cares and
Yeah.
yeah, no, I agree. And so, but yeah, I mean, I've had some that comment like, "Well, I came to you because you're a female." I get the same amount, if not more. "I came to you because you're military,"
Yes.
and they're all old veterans, and so it's fun. I mean, I will say my most favorite aspect of the military were the patients. Very appreciative, but talk about some of the old Navy guys. I mean, I was a nurse to them for everything through residency because they didn't know, like, females in the
Yes.
Navy were nurses back when they were in
Exactly.
World War II and Vietnam and stuff.
Yes.
It just was a new foreign concept to them. They're like, "Wait, you're the doctor?
Yeah.
Surgeon? What?" "Yes, sir."
That's fun. I was
It
gonna
was
say
fun.
that's nice.
There were some lots of
Yeah.
good stories, but
Yes. So, what do you counsel your patients on to try to help with their rehab or prevent other injuries when you see them?
yeah, so and this has been something that I've learned and grown from even throughout practice and then after fellowship. So, training under Dr. Andrews, he was a big advocate for athletes and keeping them on the sports field. And I think first and foremost, that's what we want to do. We want to avoid the point where they get the ACL tear or, teaching them to listen to their bodies, doing the proper warm ups. So, anytime people, and especially midlife, I mean, now I'm as that myself, thinking that I'm back in high school and can bounce back, it's not the case. And just coming to terms with the fact that, okay, my recovery is longer than it used to be, and I need to listen to the aches and the pains and the soreness, and taking that time to really build a structured buildup to your activities and goals instead of just jumping in and thinking, oh, yeah, I haven't run in 6 months. I can just go run 10 miles. It doesn't happen anymore. And so those dynamic warm ups, really for the youth athletes, I think the single best thing, and I did not listen to this in my youth, but that sport specialization that has been pushed more nowadays and playing year-round baseball and year-round soccer. It's not great for the developing, growing child. And so they can play year-round sports as long as they're doing different sports because it's a different activity to the muscles, the growth plates. And so it's not putting the same strains on them, but they need the periods of rest. And like all of us, that's going to vary depending on the patient, the age, and where they are and, their abilities. But making sure they're doing the proper warm ups. And then biggest thing is core.
Mhm.
Everything comes down to the core. And I'm sure you see it for foot and ankle. The number of injuries that and pains and overuse things that are just from their core's weak, their hips are weak, and it's knee pain and foot and ankle pain. The old school everything's connected is true, but really focusing on good dynamic warm ups, stretching, cool downs, and the recovery and sleep I think matters, and then nutrition.
Mhm.
How about you?
Same. I feel like I spend pretty much half of my visit talking about those same things.
Yeah.
And there's been a lot more focus, so I think it's helpful from that standpoint on core and posterior chain, glutes, hamstring, kind of
Yeah.
pelvic stability. So much of our balance comes from there. And if that's weak, ankle sprains, those kind of things. There's actually a recent study that kind of compared ankle rehab versus just doing core and posterior chain and not even really focusing on the
On the
ankle for
ankle.
ankle sprains.
That's
And
awesome.
they significantly decreased re-injury with core and posterior chain exercises. And so same thing. I have some athletes that'll come see me. I say a lot of kind of cross country and track runners, and that same idea of running 5 to 7 days a week. And there's been athletes that have been like, your body just can't take it. Some people can, some people can't. You've got to work on your core, work on your strength. Definitely flexibility.
Yes.
Flexibility is key.
I'm so guilty of that.
Yeah. I know.
Lack thereof.
I'm like, do as I say, not as I
Yes.
do. And
Yeah.
like you said, getting older, I've noticed even, flexibility wise, I tried to work more on those things that I used to ignore and get away with as a kid, and seeing a lot more of the older population that's trying to stay active, which is great.
No,
They're
it's
playing pickleball and
Yep.
they're golfing and they're
They
playing
are
tennis.
way more active and I think more
Yes.
knowledgeable on it
Mhm.
too. And I've noticed the conversation is now more interactive than counseling. They're already aware of a lot of this, which is nice, but the importance of your protein intake, the importance of sleep and how to do these things, but they just need some kind of assistance.
Yes.
And they all know their, a lot of them do know core, but I feel like a lot of times they don't understand the pelvic stabilizers and those other big muscle groups that factor into all these down the chain kind of injuries. But yeah, and the young boys, they need stretching and flexibility more than anything. Their bones grow so much faster and their tendons don't
I know.
don't catch up.
I'm like, you need to do yoga or ballet. And they
Yeah.
kind of laugh. And I go, but I'm really kind of serious.
But most of the
Yep.
NFL, those football players
Oh, yes.
do.
Yep.
And they're now incorporating a bunch of yoga in big corporations.
Yes.
Amazon, they have their employees, they have trainers working with their employees and saying, yeah, we know you do this, but you start the day with
Yeah,
yoga
they do a warm up
and a warm
in
up
the
and a
mornings.
stretch.
Yep.
I think it's great.
I was gonna say I would love to have that here, have
I
like
know.
a facility.
Morning PT
Exactly.
brings me back to Navy days.
Yeah. I didn't have to do that. I kind of did it on my own.
Yeah.
So I'm more of an afternoon exerciser anyway.
Yeah.
So
Well, on a similar, how much do you think the foot and ankle factors into hip, knee, and athletic performance overall?
significantly.
Yeah.
Like you said before, everything just is a chain and it all works together. And it's amazing to me. We all are so subspecialized now, so we see patients and we kinda get stuck focusing on, the ankle or the foot or whatever, but I keep reminding myself everything is all works together. And so, especially flat feet, cavo varus feet, people that have
Yeah.
really high arches,
Oh, their ankle
obviously.
sprains.
Exactly. They're gonna, they have much more instability. The flat-footed patients, obviously, it affects their knees. Patients that have hip aneurysm where their hip kind of rotates out obviously are more at risk for other types of injuries, and so all that kind of plays together. And so it's trying to get patients to focus on that and realize, hey, this isn't just coming from your ankle or hip or knee is key for their kind of long term. And then also when they have deformities, how it affects everything else. I always find it interesting. There's that argument of which do you fix first?
Yeah,
Like someone has a
chicken or the
bad
egg.
foot, they have a bad knee. And I think as long as you work together,
Yeah.
we have total joint guys that all talk to him, which do you fix? Well, it kind of depends on what they can tolerate and if they can
Yeah.
rehab, which one's bothering them more.
Well, and even with some of how stiff they get, like, well, you need to be able to move this to be able to rehab that part.
Correct.
And so you've got to weigh
Yeah.
sometimes.
And there's no perfect answer every time.
No.
Like sometimes we fix the foot first because they can't be, they can't depend on that knee or whatever, or they need to be weight bearing to rehab their knee. So all of that kind of plays together.
Yeah. And I forgot to, when we were talking about balance and the importance of that, I mean, how much that factors in for women's health and the fragility fractures with hip fractures.
Yes.
It's key. And it's funny because, I think that people are understanding a little bit better the importance of physical therapy. But there's so many that are just, they fight against going. I'm like, yes, just go twice. Just get that first eval and have them work with you a little bit. If you really feel you can do all of this on home with no guidance, then fine. I wave the white flag. But you know what? Most of the time, if they have a good therapist that's engaging with them, they come back and they're like, yeah, it did really help.
Yes.
So,
And I see it too a lot, even with neuropathy patients and things like that,
Yeah.
because obviously their balance is terrible.
Yeah.
And it's like if you work your core, you work on these things, it definitely affects it. Is
Helps.
it going to make your neuropathy go away? No. Is it going to make you normal? No. But it can at least help. And like you said, especially with osteoporotic fractures, fragility fractures, things like that, building up muscle, staying active, and helping to build that bone back is key. And there's a lot of therapists even now in this area that actually focus on
Just that.
osteoporosis. And
Yeah, well, there's
I was
osteo
like,
strong gyms.
yes,
I think it's incredible. And just understanding the importance of skeletal muscle, I think, at least when I was in training, we weren't focused on it as much. I mean, muscle, we're like, okay, strains and all of that, but it's the key to everything. And the stronger your muscles are, the better your joints are, and the stronger your bones are, which means less osteoporosis, osteopenia, and all of the above. And then your balance.
correct.
So,
You also offload your joints too. So
Yeah.
even if you have arthritis, it doesn't hurt as much because
Correct.
you're not loading your
Yeah.
joints as much.
and then the other, the diabetes and all the other comorbidity things. But
Yeah. I think the crazy thing too, like we continue to learn things. And one of the things that I try to focus with patients is as you get older, your muscle atrophies and it gets
Starts in our
replaced by
30s.
fat. And so you're not going to have that same strength. So
Yeah.
it's almost like bone health. The more you can build up your muscles, the earlier in life, the better. So
Yeah.
maintaining good activity level and everything is just important and long term.
Yeah. No, I
So-
know. And we're all, we are living longer as a society as we make advances in healthcare and medicines and more understanding. So, the downstream effects of the normal age related tendon problems and muscle problems and bone problems. I mean, it matters, and you got to start focusing younger and younger to minimize the effects. But
So, Joe, what is your favorite surgery that you perform?
well, there's a couple, but I'd probably say ACL is the most fun. It's also one I stress the most about every night. Um,
So,
Ye-
why do you stress?
well, there's always, not always, a lot of times there's associated meniscus and cartilage pathology, which can add, each and of which are usually their own surgery and can add time, to the case. And then it's just,
For those that don't know, what is the difference between the cartilage and the meniscus?
well, the cartilage, the way I like to explain it to patients, is the shiny stuff on the end of the chicken bone. The meniscus is a cushion similar to the cartilage because it is a type of cartilage, but it's more of the cushion between. It's a disc shape. So they're both made up of similar structures, but function slightly differently. The meniscus also contributes to stability in the knee. And both the meniscus and the cartilage are what really factors in those injuries concurrently at the time of an ACL, are what factors in mostly for post-traumatic or arthritis down the road. The studies show by fixing the ACL, you don't avoid arthritis, which is counterintuitive because if you have an unstable joint, it's going to get arthritic. But if you stabilize it, it still gets arthritic. And so, I think some of the most research or the most abundant research we have in the field of sports is with shoulder instability and ACLs, with both of which are my most favorite surgeries. But
How do you perform your ACL?
yeah, so it's come a long way. BTB or bone patellar tendon. So the ACL doesn't tend to heal on its own. And so you can't just repair it. Most of the time, you have to reconstruct it. Now, there are some studies we're trying to have a resurgence of healing the ACL and keeping our native tissue, which is a whole other discussion in and of itself. I've tried some, haven't really bought into it. I think in a very young patient, there's a place for what they call the bare ACL, which is keeping your own native ACL and doing a true repair. But most of the time, it's tissue that we just have to reconstruct. So we steal from Peter to pay Paul. So you take another tendon of some sort and make it into a ligament. A tendon is similar to a ligament, but a tendon is the terminal attachment of a muscle to bone, and a ligament connects bone to bone. both made up of collagen, similar structure, but again, slightly different. And when we reconstruct the ACL and put a tendon for the ligament, it actually goes through a process over 9 months to ligamentize, and it becomes a ligament. But there are several options. Patellar tendon is kind of the gold standard. It's what's been around the longest, what we used first. And it
And that's
has
where you take the little bone
the
plugs.
bone plugs, a little piece of the patella, a little piece of the tubercle, which is where the patellar tendon attaches, and then the central part of the patellar tendon, and that becomes your ACL. Hamstring was the other common one. Two of the hamstrings. Problem with that is they're variable in size, and some very big muscular people will have these wimpy little tendons. And so size matters. Yes, I know. But smaller than 8 millimeters, you want to match the native ACL normal size as close to possible. And so 8 millimeters is kind of the minimal size for a graft. And so the patellar tendon, you predictably can get a 9 or a 10 every time. And hamstring just isn't that way. So then
Does the bone heal better into the bone then, a little bit more stable, or does it change your rehab to do it a different way?
it does. The rehabs are all fairly similar.
Okay.
We're also now actually using the quadriceps tendon with or without a bone plug. And that's become more of my favorite graft.
Seems like there would be less injury to the tissue.
Yes,
And
it's a very easy harvest. It's a very predictable size, like the patellar tendon, similar in that extensor mechanism. Hamstrings are a secondary stabilizer for the ACL, so you're not compromising the muscular dynamic kind of assistance.
any issues with knee pain like you would see? Because I know when I was training bone
Yeah,
patella
they do
bone.
talk about higher rates of arthritis and anterior knee pain after a patellar tendon. It's a little harder rehab because of the bone healing, but you get bone-to-bone healing in the tunnel, so it's much more secure in the long run. The rates of failure are similar across the board. There's maybe slightly increased rates of failure with hamstring, but it's never been proven statistically significant. So every graft is equal in that sense. And really, you just have to it's patient by patient. And it's a discussion that I have with them. I give them an information website, orthoinfo.com or .org. Orthoinfo.org, I think, from AOS, our academy. And it's a great website. They have patient stories. They talk a little bit about the risk benefits of each of the grafts in depth. And so, the graft harvest is a stressful time because you're taking someone's tissue from another part of their body and trying, and using it. So there's always steps that can go wrong, and then getting the tunnel placement right. I mean, there's just so much to it. And when they go well, it's a really fun surgery. The rehab after is hard. But things can go wrong. Like you can think you're drilling that femoral tunnel perfectly, and then you get too close to the back part of the wall, and now you don't have a posterior wall, and you have to choose a different type of fixation. And I was trained very well that you always go into a surgery with plan A, but you also have plan B, C, D, and all the way through,
Right.
just in case. And that's you just have to be prepared.
Do you still, I know I still, even though I've been doing this for 20 years, I still prepare for all my cases like the night before, the day before, review everything, and just kind of make sure.
I do too. And you think about it, you review the imaging, I go to sleep thinking about the steps of the surgery in my head. I'm not necessarily bringing out the textbook like I used to.
Yes.
But yeah, I mean, you run through it, and it's, it's like anything, it's muscle memory. But you do that visualization, which is a very, important part. Athletes do it all the time, and they visualize their performance, and there is some science behind it that it helps. Funny enough, on another topic, I had a friend who's oncologist literally practices the surgery the night before with
models.
the artificial intelligence, with the video stuff. He can plug
virtual reality.
Virtual reality. And there's a virtual reality program. He puts the patient's scan in there and literally will do the entire surgery on that patient the night before. I thought it was really cool.
Yeah, that is
I
pretty
haven't
neat.
found that technology yet in orthopedics.
Yeah, I haven't seen that either.
No.
I'm like, that would be nice to have though, because
Wouldn't
it's
it?
kind of fun. I mean, we have labs and things like that where you can play with new equipment, but not anything.
But not like a
along those
virtual
lines.
reality with that patient's actual anatomy and
Right.
doing a practice dry run of the case. I think it was really cool. But
Maybe we can come up with that.
I know. Then I wouldn't have. No, just kidding. I like doing what I do. What's your favorite surgery?
I probably have 2. So I like sports-related stuff. I love scopes. So ankle scopes, lateral ligament reconstruction. So basically when someone has chronic ankle instability or has bad ankle sprain and
Yeah.
doesn't heal well from it.
Which most of them
Most
still
of 'em
heal just
yes, about
fine.
90 to 95% of people heal just fine and never
Yeah.
need surgery, which is good for the patient. And so getting them rehabbed and everything, but being able to see cartilage, like you said, cartilage is basically what creates arthritis, and so seeing if there's any damage, we do have the technology now to kind of fix cartilage
Mhm.
lesions, which is kinda
It's
nice,
similar
and
to
that's
knee
a
in
fun
that regard, right? The
correct, yeah.
stepwise of, like
So basically, you clean out any bad cartilage and kind of get down to the bone level,
Mhm.
and then some of them have a little cavity, which they probably do in the knee too,
Yep.
and you bone graft that area and then put a graft
And you can
over
do
it.
that all through the scope.
You can do it all through the scope, which is fun, and it also is great from a rehab standpoint because
It's minimally
they
invasive.
yep, they have less, scar tissue and
Yeah.
everything like that. My lateral ligaments, I still do open just
Okay.
because I want them a little
Yeah.
tighter. Some of the research on all inside technique, which is basically where you repair the ligaments with the scope,
Yeah.
have shown, a little bit more
And
laxity,
that's just more
so
of a repair then,
it
right? If you're
correct.
doing it through the
If you're
scope.
doing it through the scope, they're just kind of reattaching. They do have some specialty implants that can create almost like a internal check rein to it
Yeah,
that they
the
can use.
not using
Exactly. But I find a lot of that just in talking to some of the experts and everything that have taken care of professional athletes, they've seen a lot of failures with
just
just
doing
the
that.
scope. So I
Yeah.
do mine open. And it's nice
And you
because then
use
you
a
can get
graft
I
typically
do
or
sometimes. I'll
only
do a
when needed?
graft only for reconstructions that have failed. So
Okay.
patients that I've seen that have had previous surgeries and develop recurrent
Yeah.
instability, I'll use a graft. Or I'll use a graft in patients that have some sort of hypermobility
Mhm.
or Ehlers-Danlos, the
Yeah.
collagen disorder that creates
Very
basically
stretched.
hyper stretchy elastic ligaments.
They're
So I'll
hard to
use a
treat.
graft. They are because they have
We see it all the time in the shoulder
yes.
for recurrent shoulder
I was gonna
instability
say
and
labral. Do you do anything
labrum.
special for your hypermobile people when you're doing labral repairs or anything like that?
I go slower with their rehab.
Mhm.
I think that's about I don't know
Yeah.
anything at surgery. I mean, try to take bigger bites of the capsule and incorporate that, and I just go slower because they're gonna stretch out, so
Yeah.
I just say, "For 6 weeks, we're just chilling."
Yes.
Brace and sling and try to hold them back, which is always the
Exactly.
battle.
That is tough. So, and I would say my probably my second favorite would be I enjoy total ankles. I'm very particular in who I put
I've
them
never gotten
in.
to see one.
So, well, you'll have to come
That
sometime.
would
I
be
have one coming
fun.
up. But it's just exciting to be able to offer that to patients
Well, it's
because it
life-changing
exactly.
'cause the other than that, you would do a
A
fusion.
fusion, yep. And so anytime you take motion away from a joint, you worry about the surrounding joints. The interesting thing I find is with the literature that there was a recent article that said doing an ankle replacement really did not prevent subtalar arthritis,
Mm.
and the subtalar joint is the joint underneath the ankle, which I
Yeah,
found really
that
surprising
is
because
surprising.
the only thing I can think of is because you don't necessarily gain motion with an ankle replacement like you do with knees and hips, at
Right.
least at this point, that because you still have some limited motion, there's still
Yeah.
that increased stress. So anytime you have obviously, you have decreased motion in a joint, it's gonna increase stress on the
Yeah.
surrounding joints, which
Well,
can
and there's
lead
so
to
many
cartilage
joints
wear,
in the
but
foot and ankle. I
yeah.
mean, you think about there's the ankle, then there's the subtalar, then the hind foot, and then the midfoot, and then I mean,
Yep.
it's
And they
so
all yeah,
complicated.
it all works together and yeah, but it's fun because I mean, balancing it out, you can maintain motion, so hopefully patients can maintain activity level.
Yeah.
Ankle fusions are very functional, but
Now are they
people don't
press
like
fitting or cementing?
we're press
Press
fitting.
fitting?
Yeah, so like
Nice.
I said, we've learned a lot from hips and knees, so
Yeah.
we're press fitting, which basically, for those that don't know, it's the bone actually heals into the metal,
Right.
and so we have similar to the knees, we have some trabeculated metal and some changes to the
Yeah.
metal that
Which
allows the
trabeculated
bone
just looks like that, like sandpaper type
yes.
rough
Yep.
surface.
And it actually creates almost like a cortex for the
Yeah.
bone to grow into, which is kind of interesting that the scientists have figured
I
all that
know.
out. It's
It's come a long way. I mean,
yep.
from when you and I trained where we thought everything was cemented.
Yes.
And then we thought the cement was the disease, the problem of why
Mhm.
they failed.
Yes.
And
And all
it's
cement does is like grout, so it
yeah.
doesn't really it just kinda
It's
holds it. It's not
non-biologic.
yeah, it just and so over time and it's funny because a lot of the newer total ankles, just through the FDA process, they're FDA approved for cement, but most people don't use the cement because
Yeah,
it causes failure faster. So technically, we're using things off label, but it's better for the patient.
that's
So,
crazy.
yeah. And, but even in the 20 years, the advancements in the ankle replacements have been so vast compared to, we worried 5, maybe 7 years. Now they're lasting 10 to
10 to
15
15.
years. And
Well, and
basically, you replace bone with metal and plastic, and it works.
works. I know. I mean, the hips and knees, when I trained, it was 10, 15 years. So you were
Yeah.
counseling patients. This is your first of several.
Yes.
And now we get to say, I mean, even in the younger patients, you don't have to wait as long as possible. We can do it now, and it's going to last you 20, 25 years, if everything goes well
Oh,
and,
yes.
the normal wear rates. But it's crazy. And now they're replacing, I mean, they've got arthroplasty for MCP joints in the hand. And
Mhm.
I mean,
I'll be
almost,
curious to see going forward because the talonavicular joint, which is I like into the hip socket of the foot.
yeah,
Um, when you have arthritis through there, there's not a good answer because if you fuse it, that creates a lot of stiffness because it basically
yeah,
locks down your
it
whole
locks
hind
down,
foot.
which is your
Yep.
ability
So
to
you have
accommodate
walking
uneven
on
ground.
uneven ground and things like that. So it can be really disabling. And I'll be curious if we can ever, in my lifetime,
Fix
figure out
that.
a way to replace that. I would think that the hardest part of that would be getting that joint open enough to get in
It's
some
just
sort of implant.
visualization.
Mhm.
I know.
Yeah.
I mean, we've come a long way, and I wonder with technology, I mean, with the robotic assistance and that type of stuff, but you still have to get the
Yeah.
anatomy and the visibility
Yes.
and access.
Yeah. And the three-dimensional, like the 3D printing, I think may provide
Yeah, to be
some
able to get
opportunity
guides
there.
or something
Yeah.
for patient specific.
Yes.
It
And a lot of the ankle replacements have patient-specific guides. You can even replace the whole talus, which is, um, I mean, crazy to me that you can get a CT scan of your opposite ankle, and they can create a talus that basically matches what should be in the other ankle. And
it's
it's a
crazy.
relatively easy surgery. Like, it's crazy to me that
I
you can
went through
replace a whole
residency
bone.
hating that bone.
It is a tough bone because
It has
obviously, the
the
blood
blood
flow
supply
is
is
yes,
tough and fractures there. You're just like,
yes. And in the military, you probably saw a lot more of them.
we did. I mean, and,
Mhm.
the extruded talus and
Yes.
partial, the dislocations in the foot, just the high energy. Yeah, we
You
did. I remember one case, I mean, you had the bone graft, they kinda windowed it, and it went on the floor, and we're just like, I mean,
Oh, yeah.
and you had safety checkpoints and stuff, and the patient did
Yes.
fine, but you're just, like, in that moment, you're
Yes.
like,
Yeah. There are definitely moments like that in the OR.
yeah.
And the other, with foot and ankle, and I'm sure sports too, there's so many new things coming around the horizons.
Oh, I
I
mean, the
mean
field of regenerative medicine in
mhm.
sports is just wide open, I think the biggest problem now is because the information is so out there for patients, they come in thinking, "Well, I can get this and stem cell this and all of that," and we're just not there from what the data shows. We're making great improvements, but we still can't regrow cartilage. We can't reverse or stop arthritis. We can minimize it. We can fix some things, but
Mhm.
it's
Yeah.
just it's hard. But I have found that, platelet-rich plasma, I use it a lot in my practice, and Andrews Institute in Birmingham and Gulf Breeze, I mean, they are leaders in the research on stem cell, BMAC, and all of those modalities. I think the PRP is the most versatile with the best evidence for a
A
lot
lot.
of problems, chronic tendinopathies, arthritis, especially the knee. And so I use it a lot, and I at least have that discussion with patients. I've used it personally for my tennis elbow, and has not come back, knock on wood.
Fantastic. Well,
Yeah.
and I think PRP too, because it's basically your blood, it's
It's
easier
safe.
to access,
Yep.
it's safe. You can do it in the clinic because you can spin it
Yep.
down, you can do injections back into it. I think there's a lot of misconception about stem cells, and
Yes.
people think they're getting stem
Stem cells.
cells, and there's all kinds of fly-by-night places that you can get injections and you're not really sure what you're getting.
Yep.
I do a lot of bone marrow aspirate in surgery where
Yeah.
basically I aspirate bone marrow, concentrate it, and use that for my graft. So, we used to use a lot of iliac crest grafts, especially for my big reconstructions and things like that,
Which
and
is
it's
always
so painful, and
so
patients
painful.
have
They
more
complain of their
problems
hip
out
pain
of
more
their
than
hip.
the site of
Exactly.
surgery.
So the bone marrow aspirate's been kind of very helpful from that standpoint because you can use other sources, and so you can use that on, donor bone instead of using the patient's
Yeah.
bone. I usually kinda do a mix or almost like a slurry of things to try to help with
Yeah, I mean,
healing,
any
which has
fracture
been helpful.
non-unions, we've used it, and
Mhm.
now, I mean, there's so much research looking at augmenting the ligament healing and tendon
Okay.
healing and things with it too, so and the cartilage. I found some of the thing I think is most difficult to treat are those insufficiency type fractures from early arthritis, moderate arthritis in the knee. When you get the bone that you probably see it in the foot and ankle, I mean, the bone swells, but it's a fixed space and they just hurt.
Mhm.
And that subchondral bone, which takes so much of the load, and that just you have a bad meniscus tear, you have a bad cartilage injury, and so it's seeing the force, and you can't fix the cartilage problem. And then how do you help pain relieve without trying to tell them, well, we can cut your bone and realign you, which is a big, long 9-month thing. And they're like, no,
Yes.
thank you.
Yes.
Um, and there's some better evidence with the what we call subchondroplasty, which is kind of drilling and decompressing that area, but using the biologics, the PRP and the bone marrow aspirate to help heal. And so it's kind of got, when you all the aspects of what you need instead of filling it with cement, which is non-biologic. Like
Right.
not really gonna, I don't know,
Yeah.
help as much, I don't think. And so I think it's really exciting to be in orthopedics with all the advancements and the technology that's coming. It's forever changing our field. I mean, there's things that even me, I bet you in particular, like with the total angles, like you never saw that in residency and you've kind of had to learn it as the technology has developed, which is kind of cool part of what we
Yeah.
do.
Luckily in fellowship, they were relatively new, but they had come out, so but the agility that we used isn't even on the market
No.
anymore,
Yeah. I mean, the
and
initial
so
implants are very
yeah,
different.
they're gone, and I think foot and ankle's fun because it is relatively new and there's always kinda new things coming along. We have minimally invasive techniques now where we're using small burrs to cut bones and fix bunions
Yeah.
and fix hammer toes and do, um,
A lot
getting people so they can weight bear
a lot of
earlier,
realignment.
and so it's kind of nice. Also, another good place that I've seen it is in diabetics that get deformities and they get a pressure point and they
Yeah.
get this ulcer. Trying to do a big reconstruction on some of those patients,
Yeah.
they have horrible healing potential.
Yeah.
And you've got to do something because they're going to end up with an ulcer with infection and they're going to end up with an amputation. And so, even utilizing those burrs to just shave down a little bit of bone to get rid of the bony
Yeah.
prominence, it's not perfect, but it gets
But
people
it
back
helps
on their feet
allow
and
that
helps them.
wound to heal and
Exactly. And I've had, from a bunion standpoint, I don't use it as much as some other people just because I feel like I see kind of the more severe bunions. And so you worry about recurrence risk and things like that. But in patients with comorbidities from diabetes to smoking, it's great to have an opportunity to be able to just make a small bone cut, shift the bone over through a small hole,
yeah.
put a couple screws across through a small hole, and kind of realign and get rid of that deformity. And so I've had some success with that, and it's been fun to see patients that you wouldn't normally operate and now you can, or patients that just don't have the opportunity to be off their feet for 6 to
Yeah.
12 weeks to let bone heal.
Yeah.
And because you're maintaining the periosteum or the bone lining tissue, they heal crazy
Crazy.
fast. It's
It's amazing.
yeah.
I mean, it's similar, a little bit similar with like shoulder. We used to do all these big open Bankart repairs and ladder J's for shoulder instability, and now I do it through 2 1 centimeter incisions.
Yes.
And it's just insane to think of how we've come and progressed in what we can do through a scope and the minimally invasive techniques.
Yeah.
So,
And just from a pain level, it's so much easier.
recovery night and day.
Yeah.
I mean, open rotator cuffs was the standard, and now I haven't done an open rotator cuff since residency.
Yeah.
You just don't, unless there's a fracture and you're
Right.
doing, you just don't have to. You do it all through the scope. It's so much better visualization, less soft tissue damage, and healing rates are better. Um, Postoperative pain,
Mhm.
rehab is easier. Yeah.
Do you do mostly blocks for all your surgeries?
I do. All rotator cuff, shoulder instability, they get an interscaling block, which helps, for the postoperative pain. Major knee stuff, the total knees, the partial knee replacements, ACLs, big meniscal root repairs. If it's just a more of a simple debridement for the knee, not necessarily. But yeah, they get blocks. I mean, that's drastically helped too, having, the ability of anesthesia to help do the blocks. You don't have to have the indwelling catheter and the pumps anymore like we used to.
Yeah.
How about you?
I use a lot of blocks kind of for my bigger reconstructions. Like you said, on the smaller things, oftentimes won't.
Yeah.
Very patient specific.
Yeah.
Most of my patients don't like to take opioids.
No.
There's
I think
they just make you
most of
feel
them are
bad.
asking
Yeah.
for alternatives, and they're like, "I don't want
Exactly.
the pain meds anymore." I'm like,
Yeah.
"Good, I don't wanna give them to you."
And the
if
good
we
news
don't have
is,
to.
like, looking at the research of, like, fracture healing, so
Yeah.
when people have broken bones, we used to think that anti-inflammatories were bad for
They're
bone
not.
healing, and they're not. They don't really affect it, and so being able to manage people's pain without opioids so that
Yeah.
they don't have the nausea, the constipation, all that kinda stuff that goes
Yes.
along with it, and the risk of addiction. I mean,
Right.
that's always in the back of people's minds, so it's been kind of nice to know that we can use normal modalities, and I often tell patients, "You're not gonna be pain-free."
No, I think it's a very long, involved conversation of what to expect, and that matters. I mean, rotator cuff surgery hurts. I mean, I have people tell me I'd rather have my knee replaced again than a rotator cuff, and I'm like, it's kind of crazy to think, but okay. And so I think if you let them know up front, they're not caught confused and
Unawares.
upset and unaware, and now they're miserable for those first 72 hours. And I think the rehab, I find getting them into physical therapy for a lot of what I do in sports, I don't have to cast them, splint them for things, is better because they can then help reassure the patient this is all normal. This is what to expect. They can help with the tissue swelling and the inflammation with other modalities, the cryotherapy, the icing, and things that can help decrease that pain
Yep.
level and make it a lot more tolerable. So, yeah.
Agreed, I think. All the modalities that we have. I think the thing that I find the most with my patients, it's so hard to be non-weight bearing and to just be. And so I'm always like, act like a brand new baby. Like, stay at home for 2 to 3 weeks, elevate ice, let everyone else take care of you. Do what you need to do,
Yeah.
your activities of daily living. But I liken shoulder surgery to foot surgery because people are just miserable. And I don't know if it's really the pain that they're miserable from or that you take a normal active person and you
That can't
tell
do
them
anything.
to just chill.
Yeah.
And that's hard.
Well, and I think they don't understand, I mean, it's hard to figure out that, oh, it's my non-dominant arm, that won't be that bad. You need your
Mhm.
2 hands for a lot, like
Yes.
pulling up your pants. Like, it's
Yes.
kind of impossible to do one-handed.
I
Just your
remember when I broke
basics.
my wrist, like, it's so funny, like, what I learned during that I share with patients now
Yeah.
of, hey and just little things of activities of daily living that you don't think about,
I
and
know.
if you've never been in that situation, it's hard to put yourself.
Yeah.
And I actually a lot of times send patients to physical therapy before
Before.
surgery so that they know
Love
how to use their
prehab.
crutches, they
I
know
wish
how to
insurance
get
would buy
around.
onto the
I
prehab
know.
concept
Yeah.
as well as the icing.
Yes. Yes.
No, I think it helps. They know
Yeah.
what to expect. Hearing
Mhm.
it from multiple people
Yes.
helps because 'cause they're like, "Oh, okay, well, she said it, he said it. I guess it
Mhm.
must be true."
Yes, and I try to
Oh, and the
educate
internet
just like
said it.
you. Yeah, exactly. Everyone looks to the internet, so hopefully
Yes.
they're getting good information.
Yeah.
So, like you said earlier, I think that's one thing that I always tell my patients. I'll send them to the, American Orthopedic Foot and Ankle Society
Yeah.
website because there is a lot of information on there, and it's good relative information that's scientifically based, so they're
Yep.
getting a good source, and the AOS, which is the Orthopedic Academy, also has a lot of good information. I do get nervous when patients come in with all their, "Oh, I saw this on YouTube," or and so it's like, if they're gonna get information, I want them to get it from a reliable source.
Yeah. It has added another element to what we
Yes.
do that I don't think was there 20 years ago. Um, I think it's good on some regards because they come in more educated,
Mhm.
and so it's more of an involved discussion, but sometimes it's bad information and not trustworthy. I mean, yeah. Well, this has been great. Thank you, Tracy, for talking. I think it was a great discussion, and thank you for listening. And that's a wrap.